Adelaide and works in private practice there at Sportsmed South Australia. He's a senior medical officer for Port Adelaide Football Club. He's a medical officer for the Australian cycling team for Beijing and the London Olympics. So Mark, thank you very much. Thanks, Brendan. This is the warm-up act before the rock stars come out. My interest in cardiac screening was only just in the last 12-18 months since I attended the Monaco IOC conference last year and listened to the world leaders on cardiac screening, Jonathan Dresner and Antonio Pelliccia, and Professor Pelliccia's figures I'll refer to quite frequently because he's published quite a lot. But I came back from that conference wanting to sort of know, well, what's the Australian experience in relation to cardiac screening in our elite sport. And this is the graph that is universally shown around the world regarding the success rate of cardiac screening in Italy. So you may see this graph a few times this morning, but it clearly shows over the last 20-25 years there's been a significant reduction in the incidence of sudden cardiac death in the screened active population, which is the solid line, and the dotted line is the unscreened non-active. So in fact, it's actually recent times has actually dropped now below the unscreened non-active population. So the Italians can proudly boast that they have reduced that incidence quite significantly. The other thing that's been well confirmed is that the African American athlete is more prone to sudden death. In the US college athletes, the rate is roughly 2.5 per 100,000. But in the subset of male basketballers, many of whom are the African American origin, it's 15, so about 6 times the rate. So they're at very high risk. So the other thing I wanted to know is our Indigenous AFL footballer at any more risk compared to his Caucasian brothers. So in the season 2011 of AFL football, I undertook a survey of all the AFL football clubs. That year there were 17, there are now 18. I received 14 responses. Of those, 6 clubs that season did not screen, so I got data from 8 other AFL clubs who had screened in the season 2011 or the previous year, 2010. Of those 6 clubs that didn't screen, 2 clubs had planned to screen this year, 2012, and the other 4 clubs replied that they were either not going to screen or were unsure. So currently, even the attitude in Australia is it's not a universal policy to screen all elite AFL footballers. So I managed to get data on 360 players, 10% of whom were Indigenous. All players have had previous screening history and examination, and 90% of these players were having their first time screening resting ECG. There was only one AFL player with a known pre-existing cardiac condition, which was a supraventricular tachycardia, and interestingly, his ECG was normal. That was obviously known because of symptoms. As I said, based on history, only one player had a known history, and that included family history of all those screened. Similarly, cardiac examination revealed only 2 players where something was suspected and their ECGs were normal. So that confirms the general worldwide opinion that history and examination don't contribute a lot to cardiac screening and our attempts to reduce sudden death, although family history is obviously fairly significant. But of the ECGs performed on these players, 22 or 6% were regarded as abnormal. But the thing that was of most concern was that ranged from 0 up to 25%. So some clubs, most clubs have a squad of about 40-45 players. Some clubs revealed that no player required further investigation, and one club, which happened to be my club, 25% of our squad were referred on for further investigation, which illustrates clearly that it's very reader dependent. These are obviously done Australia-wide by a variety of sports physicians and cardiologists, and clearly this study suggests that there's no universal agreement regarding what might be considered normal or abnormal. but I think Maria will probably be able to enlighten us a little bit more about the criteria. The good news is there was only one Indigenous player, which is only 3% revealed an ECG abnormality, so there's a suggestion that the Indigenous AFL footballer is no more at risk of these sudden death from this screening. Now that doesn't take account of things like coronary artery disease. These are just resting ECGs only. So those that require further investigations, 20 echocardiograms, 4 exercise ECGs, 1 MRI. Obviously, some individual players had a combination of those, depending on whatever abnormality that was found. But of the whole group, 3 players required further investigation. 2 of those actually were diagnosed with Wolff-Parkinson-White syndrome, and they both underwent a catheterisation and ablation. Now, I'm not aware whether those players actually had symptoms or whether this treatment was based purely on the screening, but in the light of those who attended Maria's talk this morning, I've interested in her comments as to whether it's appropriate to intervene in an asymptomatic individual. The third player was interesting, was again my club, had an echocardiogram and MRI which revealed right ventricular dilatation with some hypokinesis, which is of concern that that may be criteria for ARVC, arrhythmogenic right ventricular cardiomyopathy. At this point, considered not to meet strictly the criteria, but he's being followed on any basis by our local cardiologist. His ECG revealed a sinus bradycardia, right axis with incomplete bundle branch block, which just met criteria for investigation. But some experts might argue that didn't require investigation, so the sensitivity, specificity rate is by no means perfect, but it's getting better. Anyway, no AFL player was excluded from competition as a result of their cardiac screening. There was one unintended consequence. One player was discovered to have a patent for amyloid and was just advised to avoid scuba diving based on the risk of air embolus. When asked, the medical officers of clubs replied that they plan to screen in the future on a 2 to 3 yearly basis. They were asked to put an age limit on whether they were going to stop screening at a certain age. Some said no age limit, some said we'll stop at 25, some said we'll just keep going while they're on our squad. So to put this all in context, this is one of Policia's great papers published in 2007, and I've just drawn you, this is of 32,000 subjects, so it makes my 360 AFL footballers pale a little bit in comparison, but just make a note that, and most of these were sort of social sports people, not elite athletes, but his figures were around about 12% ECG abnormalities justifying further intervention. And these are the criteria that have now been generally recommended, because the dilemma has always been in the past that what's normal and what's abnormal in an athlete's ECG. And so, at least at this point in time, the criteria regarding what's abnormal is on the right side, group 2. On the left side, those ECG changes are very common in the athlete, but if they show any evidence of changes in this group 2, that warrants further investigation. Even that in itself is controversial. For example, just the first item, T-wave inversion. Some people say any T-wave inversion in a lead should be looked at. Others argue that it should be at least 2 or 3, and in what leads they occur. So it's certainly not black and white. But just to compare our figures with the Policia figures, we divided them into 3 groups. One was the conduction abnormalities, so they're things like bundle branch blocks, prolonged QT, repolarisation. We had an incidence of 1.6%, Policia's 8.6%, and these figures were based on the recommendations prior to 2010. So this explains a lot why Policia's figures are a little bit higher, because they tend to be more conservative or want to over-investigate certain abnormalities. But the second group, we got a little bit closer, so that was the morphology group, left-right ventricular or atrial hypertrophy, axis deviation, we had 2.5%, Policia's just under 1%. And in the third group, almost identical. These were the distinct ECG abnormalities such as T-wave inversion, ST depression, readings that are probably less open to interpretation. Either you've got T-wave inversion or you haven't. And almost identical, 2.2%, 2.3%. So I was quite impressed by the fact that we were around the mark in relation to the world experts. So just to briefly make a comparison, our 360 elite AFL footballers versus 32,000 students, our abnormality rate was 6.1% versus 12%. With the more recent rigid criteria of the 2010 recommendations, that does get collegiate figures down to 5%. At my own club, where it was very reader dependent, if I applied the more recent rigid criteria, I managed to get ours down from 25% down to 13%. So statistically, in an average AFL football club, in any one season, if you cardiac screen your squad of around about 45 players, you can expect roughly 3 to 5 players may require further investigation. Is it cost effective? Wheeler argues in a paper that it only costs $89 per athlete for an ECG and yields a cost-effective ratio of $42,900 per life saved compared to history and examination alone. In Adelaide, it cost us $30 for a screening ECG and report, which I think is quite cheap given the potential benefits, albeit rare risk of sudden death. So the advantages I've discovered, certainly at AFL level, it's simple, it's cheap, the sensitivity, specificity is improving. It does identify unknown cardiac conditions. Exactly what we do about them is still controversial. Some minor disadvantages, it is time consuming. It does create some anxiety in the individual, particularly when you tell them they require further follow-up. But I found most AFL footballers coping with it fairly well. And of course, it may have an impact on their career if we do find something of concern. But so far, we've found, at least in season 2011, there were none of any concern. So my feeling is that, certainly at my club, my plan will be just basic cardiac screening of all players with history and examination and a baseline ECG. We should use 1 or maybe 2 cardiologists to do the reading, particularly those who are experienced in reading athlete ECGs. I plan to do mine 2 yearly and also plan to do them indefinitely whilst I have them on my list. There are some well-reported incidents of cardiac arrhythmia in cyclists well into their 30s whilst they maintain professional cycling. So I think I certainly feel obliged to monitor them until such time as they are no longer on my AFL list. Does it prevent sudden cardiac death? Well, we don't know that. All we're doing is finding these underlying cardiac abnormalities, but it's too early to even tell whether the success rate in Australia is likely to have an impact. And my other area of concern, obviously, is you'll find that all this research we're doing, AFL and the sports institutes, is primarily on the elite athletes, and my only concern is that there's obviously a subculture at the grassroots level of amateur football and local state league that's missing out on this, and that's my concern, is that's where something might occur in the long run. So I think we might need to be able to convince our public health people that it might become cost effective. So that's my AFL experience. Thanks.
Yeah, thanks very much, Mark. That's a really good run through the situation with the elite athletes in AFL footy. With Mark, he'll be part of the panel and questions and things later on. So moving on to our next speaker, and there'll be questions immediately after for Jeff, just because of the format of the program. So our next speaker is Dr Jeff Verrill, and Jeff is a sports physician practicing full-time sports medicine at SportsMed SA, so we've been infiltrated by the South Australians today, both from SportsMed SA so far, and that's in Adelaide. He's the medical director of the South Australian Sports Institute. He's also a part-time self-directed researcher with an interest in groin and muscle injuries, which is where I've heard Jeff speak before on a number of occasions, and has numerous first author peer-reviewed publications in both of these areas. This research is ongoing, with current interest being in the mechanism of hamstring injuries and tendon injuries. Recently has completed a book. Enough? Yeah, he's told me that's enough. So, all right, without further ado, I'll let Jeff get started.
Thank you. Thank you very much, Brendan, for arranging this symposium and for asking me to speak here. So I'm a sports physician from Adelaide, and that's the title of my talk. I'm going to race through this early bit, but why do we screen athletes? The aim of pre-participation screening is the prevention of sudden cardiac death. And since 1996, this has been recommended by the American Heart Association and confirmed by other international bodies that screening for athletes is justified and ethical, legal and medical grounds. The sudden cardiac death incidence in athletes is difficult to estimate, and it's been thought to be 1 to 3 per 100,000 years, with males 9 times more likely than females. In Australia, the information that exists, Mark Young's paper in 1999 showed the incidence in the Northern Territory football players was 20 per 100,000, but most of these were considered to have ischemic heart disease, and he extrapolated figures on Victorian footballers and said it was 0.54 per 100,000 years. What are the causes of sudden cardiac death? The most common are the underlying inherited congenital cardiac disease, such as cardiomyopathies and congenital coronary abnormalities. One of the aim of pre-participation screening is to prevent sudden cardiac death, or at least minimise it, by detecting intrinsic structural or electrical cardiovascular disorders of increased risk for sudden cardiac death. Athletes are a prime target because they have 2.8 times more incident risk of sudden cardiac death than non-athletes. And it's a public health dilemma for all ages, because when we exercise, we're more likely to die, but after exercise, we're more likely to live longer. Now, how to screen? That's also debatable. There's some evidence that ECG as part of any pre-participation screening is useful, but others would argue that we'd be better off with secondary prevention with improvements in resus and emergency plans. So, on the background of that, the National Elite Sports Council in 2011 recommended ECG screenings for all new athletes on institute programs. And so the aim of the SASI study, South Australian Sports Institute, where I work, was to look for the presence of ECG abnormalities in the context of Australian elite sports, which had not previously been performed, to establish the ease of performing the study using existing infrastructure with additional resources, and possibly to establish risk groups for possible better targeting of ECG screening. So our study had ethics approval through the AIS. All athletes have the 12-lead ECG. We got a grant from the South Australian Government for the equipment, and we had an agreement before the study on the pathway for further investigation if required, and review of any adverse sports participation findings. We had signed informal consent. We had 270 SASI scholarship holders with a mean age of 19, which is young compared to other studies. The range was 14 to 46. Years that they'd been in a SASI program was 2.3, with 90 of these having been in the SASI program for longer than 3 years, with 180 with 2 or less. We had 24 sports at SASI, with 14 of these sports having 5 or more participants, and we divided them into individual sports, which are mostly the endurance sports, and the team sports, which are mostly endurance power sports. They all had a 12-lead ECG. We had 3 cardiologists look at the ECG as well as myself, and we tried to look at the S guidelines as a guideline, and we had consensus agreement through the cardiologists to decide who would have further investigation. And our results in our normal ECG, we had 63 athletes completely normal, 68 had bradycardia only, and 51 had incomplete right bundle branch block and bradycardia, and easily identifiable to me anyway, and accepted athletic normal. So we had 182 normal ECGs. We had 88 abnormal ECGs. Now, abnormal ECGs is not under the definition of Group 1 and Group 2, but 8 of these were considered to have further investigation, principally for the suspected findings of cardiomyopathy. 3 others had had previous investigation, and none required exclusion from sports. So of the 272 athletes, we had 182 normals and 88 abnormals, with 11 of these 88, 12%, having immediate further investigation, with an overall investigation rate of 4%. This is probably a low rate compared to other athlete studies of range between 9 to 25, but it must be remembered that our study had younger athletes, and a study in Chicago of 32,000 young people showed a 2.5% investigation rate, but it was similar to the study just published in the literature from a German looking at 12 to 15-year-old elite soccer players. However, it should be said that if further investigation would have doubled if we'd strictly followed the S guidelines on T-wave inversion in V1 and V2, so our investigation rate would have doubled. This is a common finding in teenagers, with a recent paper showing that's present in 1.5% of athletes, but 0.8% of normal people. And the project is to repeat these ECGs in this population in early 2013. And some of our other findings of right ventricular hypertrophy and T-wave inversion extending into other leads such as V3 and V4 was not as clear cut. And some of the contention has been the lead placement may not have been as appropriate as we would have liked, and a future project is to look at the comparison of this ECG population with other cardiologists who work in the field, and that's been undertaken with Maria Brosnan. So our low further investigation rate, as far as analysing it, was not group specific, and we had low numbers. Our abnormal rate of 88 with T-wave inversion, early repolarisation, etc., which ones were investigated was beyond a normal sports physician. So our subgroups, however, showed that being in a formal training program for at least 3 years was a risk factor for having an abnormal ECG, as well as an endurance sport. I haven't done any regression analysis as yet, because I'm not happy about my normal definition just at the moment, abnormal definition. So what's our discussion? This is the first Australian study on Australian athletes. It's important, but it has limited numbers. At SASI, we virtually have only Caucasians in our program, and the younger age and abnormal findings makes this study hard to generalise. So I've got a couple of conclusions here. The first conclusion is a general sports physician does not have adequate training at this stage for correct interpretation of screening athlete ECGs. And the question arises, even in this study, are general cardiologists adequate, or do we need specialist sports cardiologists? Number two, to do mass ECG screenings on the Australian population, although it appears easy at first glance, will require significant input of infrastructural resources. It was a very difficult study to do, even in the context of having confined athletes through SASI. Number three, the length of time in the high intensity program, there was more ECG changes that we could consider from normal to abnormal. This suggests athlete adaptation to training load, but it has to be said, there's low numbers, there's no regression analysis, but in some respects it's unique because it was the first study worldwide to attempt to do this. And the final conclusion is that there's a low rate of investigations demonstrating there may not be a big secondary cost in investigating Australian athletes, but there's big riders on this one. Again, low numbers, abnormal ECG is disputable, and there's a problem with teenagers that I'm sure Maria will talk about when she does her next talk. Finally, in graphic form, there's that line between the 11 abnormals and the 77, the 11 investigated and the 77 abnormals was very blurred. I'd like to thank the cardiologists involved in the study and my people at SASI. Thank you very much for your time.
Thanks very much, Jeff. So we've got a couple of minutes for questions. So can I throw it open to the floor and just tell us your name and we'll ask the question if that's okay.
Chris, why was it so difficult to do with SASI? I thought you had excellent.
And I did too when I thought about it, but our database was not adequate to have all the athletes there. And we started, when we made appointments for them, some of them wouldn't turn up and then they'd have to be chased. So after they're all done to the cardiologist, and we're relying on the cardiologist to agree and bring it back to us, and then further investigation. And I think one of the athletes who was a rower at time of Olympic selection refused to do her stress echo because she said running would hurt her knees. So it was really, there was a lot of follow-up with the study, and it just ought to be that if we try to bring this to the Australian population, it would be very, very, very difficult.
Any other questions for Jeff? I was just going to ask, and mate, I'm not sure if that's your department, but talking about corralling teenagers, is there a lower age that we should be looking at in terms of maybe doing the screening?
Well, I don't think I'm the right person to ask that. It was a surprise to me to see how many teenagers have abnormal rhythms, and I don't think I was prepared for that prior to the study, and it certainly is still causing me a bit of consternation now as we go forward. But Maria can enlighten us on that one.
Are there any other questions for Jeff? All right, well, thanks very much, Jeff. Thank you. So our third speaker has come a long way from Austin, Texas, and that's Professor Bill Kohl. And I'll just read a bit of an introduction. He's a Professor of Epidemiology and Kinesiology at the University of Texas Health Sciences Center in Houston. He's at the School of Public Health at the University of Texas at Austin Department of Kinesiology and Health Education. And he's worked in the field of physical activity and health for more than 25 years. Most recently, he was co-editor of the Journal of Physical Activity and Health, and he's the founding and president of International Society of Physical Activity and Health. So please welcome Bill Kohl.
Thanks very much, Brendan. I actually learned today something I didn't know, which happens to be all the time for me, but Austin is sister city to Adelaide, and I think that's just terrific. I need to go visit my sister. Thanks for letting me know that. I'm going to present something completely different. I'm going to first establish my credentials. I'm not a physiologist. I'm also not a cardiologist. So we get that out of the way right away. I am an epidemiologist with an interest in the public health aspects of screening, and have had an interest in exercise, the risks of exercise and sports for quite a long time, both musculoskeletal injuries as well as cardiac problems. And I have started working with a group of cardiologists here in Austin and in Houston at the Baylor College of Medicine, Texas Children's Hospital, and a nonprofit organization called the Championships Heart Foundation to try to address this problem that we heard about earlier, the previous two speakers, some of the vexing clinical problems faced in day-to-day decisions by physicians, but also the broader question about the utility of screening and what are some methods we might be able to bring perhaps to improve that and get better sensitivity and specificity to make it a more useful tool, I think. So I'm going to report on our process on actually developing a registry, the Texas Adolescent Athletes Heart Screening Registry, TASER, that it's in its second year of operation right now, which is a somewhat unique approach to this, I think, in that we're addressing specifically high school athletes, not elite athletes, not people on teams or professionals and so forth, but 14 to 18-year-old kids who are part of this. So some of the background, we still, you all know this probably better than I do, but optimal screening strategies still need to be defined. Lots of people still use, particularly in general practice and in private practice, history and physical exam are utilized largely. There are still silent determinations or determinants of sudden cardiac death. By and large, for the most part, ECG has been the preferred method of doing screenings, but with changes in the echo technology, or echocardiographic technology, it's becoming easier to have portable echo, 2D and so forth, to be able to lend to as a possible approach to assisting screening. And as far as I know, no one is doing dual mode screening with ECG and echo in a field setting. Obviously there's cost benefit problems, psychological issues in the US. We have problems with health insurance, and what do you do with an athlete who might be a false positive that gets referred for a full cardiac workup and has no health insurance? It's clearly a major issue, as well as family, future professional or college athletics potentials, things like that. We do know, I think, although we don't know timing, that it could be an evolving condition in an adolescent. When do you screen? Is it early on, age 12, age 13, age 18? things change. We know very little, I think, from my reading of literature, what the natural history of this problem, of these problems are in that narrow window of time. And then the idea where I come in, I think more importantly, the feasibility of longitudinal studies. Can you develop a registry and follow false positives, true positives, false negatives, and a random sample of controls and watch conversion rates and actually bring a denominator to the problem rather than only operating on the numerators? So this is a nonprofit organization in Texas, Championship Hearts Foundation, that organizes free athlete heart screenings in the community. Limited history, echo, and ECG starting in 1999 until 2008. In 2008, that we were getting methods and so forth together. In 2008, a pilot study began, and in 2010, the TASER registry, the Texas Adolescent Athlete Heart Screening Registry, was established. This is basically community screening. Advertisements to hospitals, in the newspapers and community centers and so forth are put out, and they're free. These screenings are underwritten by the foundation, donations, fundraising, grants and partnerships and so forth from the Texas chapter of the American College of Cardiology and so forth. So this has really been put together to develop, for a twofold purpose, to develop an idea for research potential on understanding the natural history of screening, how we can better improve it, and to actually provide these free screenings to people, motivated people who actually do show up. So here's a schematic. The Championship Hearts Foundation runs the screening, and then the data flow to the Texas Adolescent Heart Screening Registry. And the data that I'll be presenting and the work has been largely analyzing the data that are associated with the TASER screening registry. Operating on a fundamental hypothesis here, and it's a statewide kind of idea. By the way, there are, I think, more people in the state of Texas than live in Australia. We have about 28 million now, so it's not an insignificant number of people. Can statewide screening of high school student athletes for HCM and other conditions actually work? Is it feasible? And can we establish a registry in order to lead to an eventual reduction in the risk of sudden cardiac death? The objective is to use community-based screenings, identify these high school athletes who are maybe at risk for SCD due to the presence of HCM and or other conditions. And then second, to establish this registry is the overall objectives. IRB approval from the Baylor College of Medicine occurred, and the screenings occur every few weeks now in hospital facilities, regional clinics, some in high schools. Informed consent is required by everybody, obviously, and it's a very logical kind of a multi-phasic screening with blood pressure, body composition, medical history, cardiac history, family, and so forth, and I think most importantly, 12-lead ECG and limited 2D echo on every kid who comes through. So we actually have both types of data in addition to the medical history part of things. Here's kind of an overview of the state. We have three different kinds, and I'll explain them later, of where the screenings occurred. They're largely in large metropolitan areas. This is around the Austin area where most of the screenings occur. Houston, Dallas, and some more rural areas down here. But we've had approximately, I guess, 30 events or so through 2012. Three different kinds of events, a traditional. We have protocols that are being followed, a manual of operations and so forth. Cardiologists on site during the screening event to give immediate interpretations of the ECG and the echo test. And then limited consults with parents and patients who were receiving the referrals for further workup. Satellite events where cardiologists are there, give immediate interpretations and limited consultations, but they aren't necessarily, what makes them a satellite is that they're not necessarily got the whole infrastructure that the traditional event does in terms of multi-phasic screening. And the mobile event, we're just now testing, and it's there's a mobile van that's being used to bring people in at large-scale events and offer screening that's available if people choose to do so. One of the strengths, I think, in these data, as I interpret them, and I don't think you should apologize for 300 or 30 screens in this kind of work, because it's very difficult work. We're able to be able to have over 3,000 people screened here. This is a gender comparison through 2012, through 2011. We've had just over 3,000 kids screened, about 930, exactly 931, or about 30% girls, and about 70.7% boys. Of the girls, of the 931, 45 girls were referred for some kind of further workup based on either the ECG or the echo, which is about 4.8%. Boys about twice that, 9.9%, 222 of the boys out of the 2,028 total screen. So we're in the same range as we've seen elsewhere. But here we're using both echo and ECG, and very few, and surprisingly very few, only less than 1% of referrals were referred for both ECG and echo findings. Medical history form, a very brief medical history form. One of the projects we're doing is to see if, to address the idea of cost effectiveness, is if what the sensitivity and specificity, varying sensitivities and specificities are of the medical history form without electrocardiographic referral or with an electrocardiographic referral, how that adds to it, to maybe think about a kind of a stepped approach to screening such that not everyone would have to go through all of the complete protocols. Another strength of this data set someone was talking about earlier is that in Texas we have a wide range of different ethnicities. And in fact, a full quarter of these athletes, the 3,200 or so athletes, are self-described of Hispanic in nature, largely Mexican American, but also Central American.